Thank you very much. Is that an omen? 13th time? Wow. Thank you very much for inviting me. It's always a pleasure. We're going to talk about basically two problems that are very basic to people who have had treatment for prostate cancer, and one is incontinence and the other is erectile dysfunction. I don't do prostate cancer surgery. I treat the complications, which are these two things. And we're going to talk about the real information that people don't tell you about and what the real facts are about incontinence and erectile dysfunction. And we're going to try and make sure that, if there's anything you don't understand, you can ask me later. All right? Now, how many of you seen Dr. Phil? Nobody, eh? So, believe it or not, so that's my wife and that's myself, and we were on Dr. Phil. And believe it or not, it wasn't because I was a great urologist. My eldest daughter, Rachel, when she was 16, wrote a letter to Dr. Phil asking him why she couldn't stay out late at night. And believe it or not, they actually invited us on the show. And Dr. Phil argued with my daughter, and my daughter's now a personal injury lawyer. Kind of funny. And my daughter argued with him, and then he turned to me and he said, Dr. Phil, he said, "What kind of parents are you letting your daughter stay out late at night?" And so when we came home, my daughter was famous in her high school, and I was a poor schmuck father that wouldn't let her stay out late at night. It's a true story. So this is my license plate. Truly it is. And so if you see this, you know who it is. It's me. My wife got that for my birthday years ago. And it's funny, I'll tell you another funny story. So I used to take my car to the same car wash it's near Yonge, near Bloor. And the guy always used to eye my license plate, and I just knew he wanted to ask me something. So about 6 months into when I got this license plate, he finally turned to me and said, "Are you a plumber?" And I said, "Sort of." Anyways, let's talk about incontinence. So I'm going to sort of stand sideways, because it's always hard to do. And actually, I'm going to take the microphone, because I hate standing at a podium, even though I've done it a million times. Can you hear me okay? Yes. Okay, good. So what is incontinence? Incontinence, or stress incontinence, is a loss of urine occurring during activities that increase intra-abdominal pressure. So when you cough, strain, do physical activity, bend over, you actually leak. And again, that's the main cause or definition of stress incontinence. Most people who have surgery have this type of incontinence. Most, not everybody. So, can you get this type of incontinence from any other type of surgery in men? Well, yes, you can. If you have a TURP, and maybe some of you had a TURP before your surgery or radiation, it doesn't occur that often, but about 2% of people get urinary incontinence after a scraping of their prostate gland or a roto-rooter. Simple prostatectomy, if you have a very big prostate, they'll take out your gland, you can get it. Or if you've had a radical prostatectomy, in 10 to 20% of people get stressed urinary incontinence. And it can be quite upsetting. Most people get a little bit after the catheter comes out, but usually it gets better. Now, when you have radiation, the incidence or prevalence of incontinence is a lot less. It's about 4%. So if you have radiation alone, it generally doesn't cause incontinence or stress urinary incontinence. If you have it combined with surgery, so if you have surgery and salvage radiation, as they call it, then it increases the risk. And some of you may have had HIFU. HIFU is high intensity focused ultrasound, about the same risk, about 4%. Now, if you look at the actual incidence, or what percentage of people have urinary incontinence after surgery, it's a little bit confusing because it's not reported well. People use different definitions. The patients report higher than the physician report. So the physician will say, 10% of my patients have incontinence, and if you actually survey the patients, 40% have urinary incontinence. And in fact, when I was at University of California, Davis, where I did my fellowship training, there was a very famous guy named Thomas Stamey. I don't know if any of you know who Thomas Stamey is, but Thomas Stamey is the guy who invented PSA. And Thomas Stamey was the chairman in Stanford University who used to do radical prostatectomies. And he would tell his patients, "You're not incontinent." And they would come to us down the street in Davis, he was at Palo Alto, and would say, Dr. Stamey says I'm not leaking. How many pads do you wear, sir? 6. But Thomas said I'm not leaking. So it really depends on the patient's perception and the physician's perception. And so the question is, what's significant leakage? So if you wear, and I'll tell you why this is important, if you wear 1 light liner per day and you change it at the end of the day and it's minimally wet, that's really mild leakage. And that's pretty acceptable to most people, not everybody. If you wear 6 pads per day and you wear a diaper to cover up the pads, that's pretty bad leakage. So for example, someone I saw today came to see me and he doesn't want surgery and wanted medication. Medication we'll talk about that doesn't work very well for this problem, obviously. And he says, I'm better. I said, well, I look at my notes and I see we're 5 pads per day. So he says, I'm better. I said, well, how many pads are you wearing? 4.5. So I said, well, why do you think you're better? Well, they're lighter, the pads now. So it's all relative to the patient. And the problem is that there's no standard assessment. We do what's called a pad weight, but nobody really does that. We actually measure what the pads weigh, and that can be very helpful to determine how bad it is. Now, I don't know about you guys, but I'm sure when you went to see your surgeon for if you had a radical prostatectomy, and they said they were going to do it robotically, and the success rate in terms of incontinence and ED is better, they're bullshitting you, because the reality is that if you look at the literature, there is no difference, 0 difference between open, robotic, or laparoscopic in terms of incontinence and erectile dysfunction. It is exactly the same. Exactly. You're better off going to a surgeon that does 70,000 radical prostatectomies a year than someone that does 1 a year. That's the reality. Okay? So that's important. So don't when someone says to you that if you do it laparoscopically, you're going to be better robotically, it's not true. It's just not true. And usually the reason that people have problems is that the sphincter muscle is injured or damaged. And we'll talk about that. So I put this slide out because we had our urology update this weekend, which is a big University of Toronto session, and I presented on the workup of post-prostatectomy incontinence, and we talked about this. So what happens to the sphincter muscle? Well, the prostate sits right on the sphincter muscle. There's a second sphincter muscle. The first sphincter muscle is at the bladder neck. Without a doubt, when you take out the prostate, you damage the first sphincter at the bladder neck. And the question is, do you damage the sphincter, the external sphincter, when you take out the prostate gland, the second sphincter? If you damage the second sphincter, then you're going to have incontinence. How does it get damaged? Well, you can take off or rip off muscle fibers from the sphincter. You can get scar tissue. You can get the nerves injured. There's so many things that can happen, and radiation makes that worse because it can cause scarring. So you can also get what we call bladder dysfunction. So in a small percentage of people, they get problems with their bladder. So the bladder's squeezing too much, but generally that's really the sole cause, rarely the sole cause of incontinence. In most people, it's the sphincter muscle is not doing well. So on occasion, when we do our testing, we find you don't have leakage when you cough and strain. You actually have a spastic bladder, and you can benefit from medication. And that's part of the reason we do some testing called urodynamics. Now, again, this is this urge incontinence. So usually when you get a good history, you can sort that out, but not always, and it's due to an overactive bladder. Occasionally you'll be in retention and leaking because it's overflow. And then sometimes if you have Parkinson's or you have some type of disability where you can't get to the bathroom, you may leak before you get there because you just can't get there in time. Now, history is very important. So, I've been doing this for a long time, and I usually know which questions to ask, and my medical students don't, my residents don't ask often the most common questions. And also we do testing called cystoscopy and urodynamics. Why do we do cystoscopy? Why do we look in? Patients always ask me that, and the answer is you can get one of the following. So today I'll give you an example. This is always the best thing. So there was a patient who had a radical prostatectomy in another hospital, stress urinary incontinence. He was told by his urologist when they scoped him that the bladder neck was open but narrow. So today he came in for an artificial sphincter. We came in, we did the testing. I couldn't get a 14 French small catheter inside his bladder. I was able to get a small 7 French to do the testing, and I know that he's probably got a bladder neck scarring. So the reason we look in is because you get scarring, you get stones forming, You get staples that have been left behind or eroded through. Occasionally there's a stricture in the urethra, even downstream. So that's the reason we look in. People always ask me, why do I do the urodynamics? I do the urodynamics because I want to know exactly what your bladder function is, to know exactly what's going to happen if I put a sphincter in. Maybe you just need medication. Maybe you're going to need the sphincter and medication. So I like to do it. It's not absolutely necessary, and not everybody does it. Sunnybrook does it. Dr. Hirschhorn, who was my mentor and who I trained with, he's still going, if you can believe that. It's unbelievable. He doesn't look a day over 30. So what's the treatment? So I love this. So how many of you have seen Leah Jemnicki? Okay. So Leah and I go way back. She was a nurse when I first was a resident at the Bell Wing at TGH. So Leah will tell you that you can do these Kegel exercises, she's going to hate me for this, till the cows come home and you will be better. Bullshit. They don't work. Okay? The reason is very simple. Unless you have very, very, very mild urinary incontinence due to stress incontinence, Kegel exercises do not work. There have been multiple studies that have shown that all the Kegel exercises do, it hastens the improvement if the improvement is going to come back. So in other words, if God predestined you that at 1 year you're going to be dry, okay, you'll be dry whether you do Kegels or not. If you do Kegels, it'll happen faster. That's the only thing that Kegels do. If you're going to do anything, physiotherapy is a little bit helpful, but again, it doesn't affect the outcome. You're going to have incontinence if you're going to have incontinence. Okay? The only thing is, if you're not going to be incontinent, it just hastens the improvement, and at 1 year, everybody's equal. So after 1 year, it's not worth doing. Biofeedback doesn't work as well. That's learning which muscles. It's the physiotherapy with an actual physiotherapist, which is costly. So that will be helpful. Now, what about fluids? Holy mackerel. I cannot believe this. So, sir, you're leaking, right? Right. How much do you drink? Lots. Lots. You're leaking. Yeah, I know. So why are you drinking so much? Isn't it good for you? Well, let me ask you a question. If you're drinking a lot, do you think you're not going to leak more? Yeah, it makes sense. Okay, so why are you drinking? Because I was told to drink. Well, why are you told to drink? Because it's good for you. Okay, so there is absolutely zero evidence that drinking lots of water is good for you. There was a paper just published in the journal Urology that showed that drinking lots and lots of water is only good for two things. One, if you have kidney stones, and two, if you're constipated. And even if you're constipated, there's a certain level you don't need. So if you're leaking, do not drink lots of water. It doesn't make sense. So we usually recommend no more than 2 liters of fluid a day. And that includes soup, salad, cereals, fruits, vegetables, and everything you're drinking. Okay? Caffeine. If you drink caffeine, caffeine's a diuretic. So coffee, tea, pop, all these things, chocolate, all these things make you urinate more. And then alcohol. If you drink a lot of alcohol, they're diuretics. They make you go to the bathroom more frequently. We recommend time voiding. So before you leave the house, make sure you go to the bathroom so that you're not stuck in a mall or you're driving in a car if there's a traffic jam. They all improve your symptoms, but they're not going to cure the problem. Now, what about drugs? So the drugs only work if you have an overactive bladder, and they improve things somewhat. If you have both stress urinary incontinence and an overactive bladder, you may find a little bit of improvement in the frequency and urgency, but generally it will not help the stress urinary incontinence, the leakage when you cough and strain. And there's two sets of drugs. There's the bladder relaxants, which we call anticholinergics, such as Toviez, Vesicare, Ditropin, Tolterodine, or Detrol, and the beta-3 agonists, which most of you probably heard of, Mirabegron or Mirabetriq. The advantage of Mirabetriq is it doesn't cause a dry mouth, doesn't cause constipation, whereas the other one can cause a dry mouth and constipation. Now, so what is the treatment, the interventional treatment for urinary incontinence in males? So if you're going to treat the leakage, other than doing conservative measures, which we just talked about, what are the options? So there are injectable agents. So many of you may have not heard about this, but there was a drug called collagen. It wasn't really a drug. It was a substance that you'd inject into the urethra. It works really well, or worked really well, in females, and then in men it didn't work so well, so we stopped using it. There's and the collagen's off the market now because they stopped making it. It was good for about 20 years, and the company was losing money. They just stopped making it, so it's not available. Bulkamid is a newer agent that we inject in the urethra. It seems to last a little bit longer, and we've been doing more and more injectable Bulkamid injections into the urethra for urinary incontinence instead of doing artificial sphincters. So we have some people that refuse to have a device implanted, and they want this. It's worked not bad, better than the collagen, but the downside is it costs $1,700 for the treatment. It's very expensive. The other option is a sling, and we'll talk about the sling, and the artificial urinary sphincter. So if you look at the artificial sphincter, it's considered the gold standard. And most people, I tell most people, that if you have an artificial urinary sphincter implanted, whether you have radiation or not, 85% of people will be either completely dry or wear one light pad per day. And 15% need something more. In almost the majority of people, everyone gets better. They may not be totally dry, but they get better. Now, how long does this device survive? So 20% of people need something fixed in 5 to 8 years. Some patients of mine have had the device in for over 20 years. And it's available only at 2 centers essentially in Toronto. One is at our place, and the other is at Sunnybrook with Dr. Hirschhorn doing them. And that's the great majority in Ontario who implant these devices. Now, what happens, or what are the complications? Well, of course, the device can get infected, then it has to come out. It can erode through the urethra. These are all uncommon, about 2 to 3%. You can get what's called urethral atrophy. The cuff just gets loose with time. I always relate this to, I don't know if you've ever had a broken arm and you have a cast, and then you take the cast off and the arm looks like half the size of your other arm. The same idea, it compresses the urethra. And then about up to 52% of people get some kind of mechanical failure where it's like a car. Basically, the device leaks or the pump breaks or something breaks, and you need to have that repaired. So again, complication rate's not that bad. And if you want to see, there is a recent publication that we did with Dr. Hirschhorn, the group of us, looking at the survival of these devices. And we looked at, in Ontario only, 76% of people who have a radical prostatectomy and have an artificial sphincter have the device in at 10 years. That's not bad. Better than a Honda. Okay? So that's not bad. And that's probably because Dr. Hirschhorn and myself are probably the only ones putting them in. And so we've done a lot. Now this is the device. A very simple little device. I didn't invent it. It's a guy named Brantley Scott in the United States at University of Texas. And he's passed away. He was a urologist. And he got, at the time, must have been in the early 70s, $10 million for this invention. That was the rumor. And it made him made a lot of money because that was in the early 70s. And he was a very famous urologist. He actually created the inflatable penile prosthesis too, the AMS one. So he created this and that. Brilliant guy. He was actually died in a plane crash. He used to fly his own plane from the American Urological Meeting one year. It's a real sad story. But he's the one who invented it. It hasn't changed much in 25 years, really. What about male slings? So the male slings have got like a renaissance over the last 10, 15 years. Usually we give it for people who have very, very mild leakage. Okay? If you have moderate to severe leakage, it doesn't work so well. And the artificial sphincter works in everybody, whether you have mild, moderate, or severe. The advantage is it's easier for the patient. All you do is put this material in, you sling it up tight, and they don't have to pump anything, they don't have to do anything. It just is there and works. The disadvantage is the success rate is not as good as an artificial sphincter and does not work in moderate to severe leakage. It's been shown to give the advanced sling, which is the one that we use now, is the best sling out there. There have been a whole bunch of other options. And you can't use it in patients that have radiation. The evidence is poor that it works, and the results are poor if you've had a radiation after radical prostatectomy. I have to admit, I've done a lot of these. I don't do very many more at this time, and the reason is I've just not been happy with the success rate, and so I don't do them. My partner or my younger partner does them. He likes them. Dr. Hirschhorn does them. He likes them. So it really depends on, and maybe it gets a better result than me, but I always think the artificial sphincter gives you the best result, and I'm pretty happy with that. So you got to find out if it's an option for you. Now, this is the sling. It basically goes underneath the scrotum, underneath the skin, obviously, and it pushes up on the urethra, and it goes through two sides of the inner thighs of the legs, and basically this mesh holds up the urethra. We actually don't know how it works, believe it or not. Nobody really knows, because it doesn't really compress anything, but it actually does compress something probably. So, multiple treatments are available for post-prostatectomy incontinence. The gold standard is still the artificial sphincter. Slings evolved into the less invasive technique, but only for mild leakage. So, what's erectile dysfunction? It's the consistent or recurrent inability of a man to attain or maintain a penile erection sufficient for sexual performance. It's usually multifactorial. Usually many other reasons why people, not just surgery. So how does this impact relationships? So, I mean, I'm not a psychologist. I don't spend 5 hours with my patients talking about relationship, but you know, partners feel like they're to blame many times. There's marital distress and sexual dysfunction that are related. It's a very common thing. ED, or erectile dysfunction, reduces intimacy. I remember when I first started, we call it impotence, and now we call it ED, erectile dysfunction. It reduces intimacy, closeness for a couple, and increases depression, anger, anxiety, which obviously affect a couple. So it puts a lot of strife in a relationship. And if you look at erectile dysfunction, without having radiation or surgery, this is an eye-opener. 52% of men after the age of 40 have some form of erectile dysfunction. It increases as you get older because there's multiple medical problems that happen. Risk factors include diabetes, vascular disease, coronary artery disease. Smoking is a really bad thing. Neurological disease, pelvic surgery like a radical prostatectomy causes depression, anxiety, frustration, affects the man, his partner, and the relationship. So it's not just a man thing. Now, it's amazing how many times, like I have an ED clinic every Friday, every other Friday afternoon, or once a month now, but it's going to change again. And I can tell you that 90% of the men that come to see me, they don't come with their partners. It's kind of weird when you think about it. I think my wife would come. My wife wants to come for me to go to my eye doctor's appointment. I said, you don't have to hold my hand. My wife even wanted to hold my hand when I had my vasectomy. I said, no way, man. That's kind of a... anyways, so what are the risk factors? Well, aging, as you get older, you know, it's like a car. It breaks down, and so there's going to be problems. Chronic disease, such as heart disease, hypertension, peripheral vascular disease, diabetes, depression, medications. So the drugs that we use for blood pressure lower the blood flow into the penis, and if you have some narrowing, it's going to make it worse. And then there's lifestyle, so stress at work, alcohol, drug abuse, and smoking. Now, believe it or not, there is some psychological aspects to erectile dysfunction, and that is depression, performance anxiety cause relationship problems, can cause all of these. Usually in people who come to see me who have radical prostatectomy, I think this is a secondary thing. This is not the primary cause of the problem in most cases. Now, if you look at the percentage of what causes erectile dysfunction, you can see the vascular disease. So that includes heart disease, that includes if you smoke, diabetes, affects the nerves and the blood flow. And you can see at the bottom, only 6% of people, this is specifically related to pelvic surgery or radiation. So usually it's all these other factors. And this is important because we're going to see why. So if you have radiation, okay, if you have just radiation, the incidence of erectile dysfunction is less after radiation than surgery. But with time, the incidence increases. And in fact, at 1 to 2 years, 50% of people have erectile dysfunction after radiation treatment. It keeps getting worse as time goes on because radiation is a chronic event. There's no, and I'm sure the radiation oncologists tell you this, they say, well, brachy's better. And that's not true. There's no difference between external beam and brachytherapy. They both cause erectile dysfunction. There's not one's better than the other. The response to these drugs like Viagra, Cialis, Levitra is good to excellent in these people, at least initially, or people who have this problem when they have radiation. It also depends on other medical problems. So if you have coronary artery disease, diabetes, and you can't walk 2 steps without having chest pain, having radiation just makes it worse. Now, what about a radical prostatectomy? Interesting. So what's the incidence is highest in older men with medical problems, less in healthy young men. We'll talk about what I mean by that. The cause is nerve injury and decreased blood flow. So it's not just the nerves. The results are best in bilateral nerve-sparing surgery. So you're better off if you're going to have the nerves spared. You've got to have both of them spared. The results are better. And the response to PD-5 inhibitors, the drugs, Cialis, Levitra, Viagra, is best in bilateral nerve-sparing surgery in young, healthy men. Okay, so you're wondering, what's young, healthy men? 75% of men, after radical prostatectomy, no radiation, in those greater than 72 years old, have ED even after both nerves are saved. 75%. I'm sure they all bullshitted to you. They're your surgeons, right? Amazing, huh? And that doesn't include if you have medical problems. Okay? No difference between robotic, laparoscopic, or open surgery. Same. Best results in those under 60 years of age, healthy, and both nerves spared. 50 to 60% will be potent. It's not 100%. It is what it is. HIFU. Any difference? A little bit. Theoretically, you can map the nerves to reduce injury during HIFU treatment. Theoretically, very precise, but again, the rate is about 25 to 35%. Gets worse if you've got multiple medical problems. There's not a lot of data, and it involves like other things. So if you have hypertension, coronary disease, the results are going to be poor, even if you have HIFU. So what are the treatments for ED? Well, lifestyle drug therapy modification. So if you smoke and you don't exercise, stop smoking. Exercising all helps. It can't hurt. Psychosocial counseling sometimes can be very helpful. We do it at the UHN. Andrew Matthews, some of you may have seen Andrew and his team do a great job. Now, androgen replacement, I know someone's going to ask me about that. It's a little bit tricky. We like people, if they have a radical prostatectomy, they feel their libido's down. We like to make sure that a year goes by and their PSAs are stable or they're zero undetectable, and their testosterone levels are actually low before we consider putting them on medication or treatment. Radiation's a little bit different. I'm always reluctant to do it in radiated patients unless they've been out a little bit longer. And then oral therapy, the PD-5 inhibitors, which are Cialis, Viagra, and Levitra. Now, very interesting, these pills, because the day, on Friday we had a clinic, our ED clinic. I had a family practice resident, I had our physician assistant, and it's amazing, they were shocked, and I'll tell you why. So we have sildenafil, which is Viagra, tadalafil, which comes in a daily dosing, 5 milligrams, and we have Cialis, 20 milligrams on demand, and then we have vardenafil, which is the oral and the melt. How many of you know what the difference in terms of dosage between the oral and the one you put underneath your tongue? Does anybody know? This always amazes me. So people come in and they say, 20 milligrams of Levitra doesn't work, but the melt does. Okay, the melt is half the dose. People don't know that. So why does it work? Well, it's called placebo effect, because it shouldn't work any better. There's no faster absorption. It's all bullshit. The company won't tell you that it doesn't absorb any faster. Now, how many of you, when they try these medications, were told that you can have sex in 15, 20, 30 minutes? Nonsense. Doesn't work that way. You guys, or people who have this treatment, have radical PE radiation. You are the hard-to-treat group. You need to take these drugs properly for them to work and optimize their effectiveness. Now, what do I mean by that? Viagra. If you take Viagra, let me tell you, you're supposed to take Viagra. You take it an hour to an hour and a half before you want to have sex. Not 15 minutes. It will not work. Only 30% of people get a response at the best of times if you take it if you try to have sex 15 minutes later. The optimal time is an hour and a half. You need to take the drug on an empty stomach, 2 hours after you eat. If you take it with food, it does not work. You know how many times that happened on Friday? It's been shown that 65% of people take these drugs incorrectly. 65%. How many of you were told nothing about the food issue? It's very common. What about Cialis? Anybody know about Cialis? You have to take it on an empty stomach? No, that's the advantage of Cialis. So tadalafil or Cialis comes in a 5 milligram daily dosing. The advantage of that is that you don't have to think about taking before you have sex. You take 5 milligrams every single day like your blood pressure pills. It works almost as well as taking a 20 milligram boost, but eliminates taking an hour before. It does last up to 36 to 48 hours, but again, you guys or the patients who have this stuff are the hard to treat group. So I wouldn't take Cialis 20 milligrams at 9 o'clock Friday night and think it's going to work on Sunday. It will not, because you are the hard to treat group. So if you take Cialis, you wait an hour and then you have sex. Not 15 minutes, not 20 minutes. And you don't have to worry about food. Now what about alcohol? Anybody know if alcohol affects it? Alcohol does not affect it, unless you get pissed drunk. Okay? Then it may affect a lot of other things, but it may leak more. But it won't affect, if you have a glass of wine, it doesn't affect the absorption of any of these pills. Now, Levitra, which is vardenafil, as mentioned, comes in the melt or the oral. It's 20 milligrams, and you take it again an hour to an hour and a half before you want to have sex. It works just as well. So people always say to me, which works the best? Give me which works the best. And the answer is they work equally effective. So if you have somebody who takes Viagra and says it doesn't work, it doesn't mean that Cialis is not going to work, and vice versa. So many times people will come in, I tried all three and Cialis works best. And the next guy in the next room say Viagra works best. So it really depends on the patient. Some people will tell you that one of them gave you terrible side effects, the other doesn't do any side effects whatsoever. So it's worth trying more than one of the drugs. And if you look specifically at sildenafil, only because it was the very first one, it restores impaired erectile function. It works only following sexual stimulation. What do I mean by that? So on Friday, we had a patient, and the family practice resident said to me, the Viagra didn't work for the patient. So I went over, I said, you took the Viagra an hour and a half before? Yeah. Did you try and have sex? No, I didn't have an erection. It doesn't work that way, sir. You've got to be sexually stimulated for the drug to work. What do you mean? I didn't have an erection. I said, no. It doesn't work that way. The way the pills work is that when you are sexually stimulated, it starts the cascade, and that's when the medication works. So you got to try and have sex. Oh, okay. So that's important. So people take it incorrectly. Interestingly, if you look at the results in all comers, 78% of people who took Viagra improved their erections compared to 20% with placebo. It works in a variety of different causes: high blood pressure, diabetes, depression, spinal cord injury, and even radical prostatectomy. And again, the 1-year open label study, 88% of patients reported improved erections. So the drugs do work. We know that. Now, what about the side effect profile? Well, the most common is headache, 15.8% of people. All the drugs do that. Flushing, heartburn, nasal congestion. These are the most frequently reported side effects, and most people don't stop the drugs for this reason. There is some unique features about some of them. So Cialis can cause what's called muscle aches and pains. Some people get like back spasms, and it's unique to Cialis probably because there's a cross-reactivity with one of the different enzymes. Now, people always worry, am I going to get a 12-hour erection? You should be so lucky. No. No, it doesn't. These pills don't do that unless you mix it with an injection, a vacuum device, and Muse, then you're not going to have an issue. Okay, so it's contraindicated in people that take nitric oxide drugs. So if you take nitroglycerin, or you take the spray, or you take Nitroger, you patch, you can't take these drugs. Why? Because they will lower your blood pressure dramatically and you'll die. So you don't use them in combination. So what it means is, if somebody carries nitroglycerin, I always say, well, have you ever used it? Well, once, every couple months. I said, well, you can't use it if you take these drugs. Okay, then I won't use it. But I said, listen, sir, if you have chest pain, you're going to forget that you're taking this pill and you're going to take a nitro. No, I won't. So inevitably, it always happens. So I always recommend at least throw away your nitroglycerin if you're going to do that. Okay? And it's very important that people understand it. And that's all three drugs. Okay, so let's break some of the myths. Does not cause heart attacks. I can't tell you how many times people come in and say, I'm kind of nervous about taking Viagra, it's going to give me a heart attack. Nonsense. Does anybody know how Viagra was discovered? So in Britain, they were investigating the use of Viagra for chest pain, for cardiac disease. Okay? What they found was it wasn't very good for chest pain and cardiac disease, but everybody was popping a boner. And they said, wow, this is kind of cool. That's how it was discovered. So these are the same as nitroglycerin. They don't cause heart attacks. Okay? Second of all, it does not increase your blood pressure or lower your blood pressure unless you have some certain combinations. Okay? And the combinations are if you take something like a drug called Hytrin. Anyone know what Hytrin is? It's terazosin for urinary symptoms. If you take Hytrin and you take Cialis, Viagra, or Levitra, it can lower your blood pressure. Okay? So you got to be careful. That's about it. There aren't too many other reasons not to be able to take it. It does not cause strokes. Anybody hear about this blindness issue? So, that may or may not be a real thing, and I'll just show you some of the data, but it doesn't generally cause blindness. There are some people that have this thing called Nion. They've had it in one eye. If you get a history of that, probably wise not to give them the drug because you never know. And then it does not cause cancer. Did anybody see the reports that it causes melanoma? So there was a report actually that people who were taking Viagra had a higher incidence of melanoma, skin cancer. That's been debunked. There's a recent paper that shows absolutely not true. So it doesn't cause melanoma. Now, what's the dose? So we recommend 100 milligrams of Viagra. You take it 60 minutes before on an empty stomach. Cialis, 20 milligrams, you're going to take the on-demand, and 20 milligrams of Levitra. I don't go start low dose and go up. I always start, especially in the higher to treat or difficult to treat patients, we start at a much higher dose and go down if necessary. Okay? Now, we went through this. Patients should be advised, okay, that sexual stimulation is needed. You can't take it once. I can't tell you how many times you take the Viagra? Once. Did it work? I don't know. I didn't have sex. Okay, well, you can't take it more than once. You have to try it a couple of times at least, probably 4 to 6 times. And then again, should be taken on an empty stomach. And interestingly, this is the most amazing thing. Erections can improve up to 4 years after the surgery. 2 years seems to be this watershed mark. So people will tell you they come in, every 6 months to a year, and they say, no, not getting any erection. And then all of a sudden at 2 years they come in and say, I'm waking up now with morning erections. Oh. And so 2 years is the watershed mark, and things may improve at that point. So what that means is every now and then retry the drugs, because you never know. And we've had that before. Now, Cialis, again, improves erectile function. It can work as early as 16 minutes, but don't do that. It only works in 30% of people at the best of times. So you got to wait an hour and a half. It can be effective up to 24 to 36 hours. I recommend trying to have sex an hour later, and no interaction with food. And again, you need sexual stimulation. Okay? Now, how many of you have heard of sexual rehab clinic? Taking these so when you had your radical P, they said, you know what? You need to start these medications as soon as possible. It's going to make you better. It's going to preserve your sexual function. You're going to be better, as good as new in a year's time. How many of you were told that? So, interestingly, there have been, the original trial were in animals, okay? I don't know how they discerned in animals, but it was in rats. The secondary trial was Viagra without a placebo, and the third trial was injection therapy. They said that, you know what? People get better if you start these treatments ASAP. So there was a big push to doing sexual rehab. So after surgery, you start on Cialis 5 milligrams daily or 25 milligrams of Viagra every other day. And then what happened? There were 3 clinical trials. Well done, designed with a gazillion patients. And what do you think they found? 3 trials, Cialis, Levitra, and I think a second was Cialis. They found that it made absolutely no difference. If you started taking the medications right away, or if you used the drugs as needed, as opposed to daily, and didn't make any difference if you decided, I don't really want to take the drugs till I'm ready to have sex. At 1 year, everybody was the same. So it does not prevent erectile dysfunction. It does not improve things at a year. You may be sexually active before a year because you take the pills, but that's it. So I was never a big believer in this. There was a big push. I didn't do sexual rehab. Many patients felt that they had screwed up because they didn't do this. They said, oh my God, at 1 year, why didn't I do sexual rehab? Don't feel bad. There's no evidence that it makes any difference. And so it really doesn't work. So I don't use it that much. If you want to be sexually active, that's a different story. Okay? So none of the well-done trials have shown any improvement to this date. Now, this is the eye problem. It's called NION. And what it is basically ischemia to the eyeball or the retina, and it causes blindness. It occurs in people who don't have any of these drugs. And usually it's very rare. It occurs in people over the age of 50 if you have diabetes, hypertension, hyperlipidemia, and the special cup-to-lens ratio. So these are people who have a lot of medical problems. It was reported by an ophthalmologist. So it was kind of a silly thing because he said there were 7 patients reported and all had been on Viagra. They didn't know when the blindness occurred relative to the pill. So it may have been 6 years ago. They weren't on Viagra anymore. It may have been 3 weeks ago. Not clear. All patients were over 50. All patients had high blood pressure. All patients had diabetes. In the people it's supposed to occur, and it occurred in. So 38 cases reported eventually in the United States. It was found that occurred in Cialis, Levitra, and Viagra. Viagra was the most commonly reported. And so what did Health Canada FDA state? No causal relationship. It does not cause NION, but if somebody has it in one eye before, don't give them the drug. It's probably prudent to do that. You never know. Now, what's the second-line therapy? So you take the pills only work in a small percentage. What do we have left? Well, we have the vacuum device or the Hoover or the filter queen. Works very well, a little bit finicky, I'll show you. Then you have injection therapy, works really well, but you got to stick a needle into your penis. And then Muse, or the transurethral suppository. Most people haven't heard of Muse. Been around for almost 20 years now. Works not bad. It's very expensive, about 35 bucks a pop. So here's the vacuum device. The one that we recommend is the Osbon one. It's the original one. It's been around for years and years and years. It's about 500, 600 bucks. There's a money-back guarantee, believe it or not. You can use it for a month and then give it back. I don't know who's going to use it after you, but they can give it back. Kind of crazy, and they do it, and that's the Osbon group. And what it is a cylinder fits over the penis. There's a rubber ring on the base of the cylinder. You create a seal at the base with some lubrication, and you basically pump the device. Now, it comes in 2 models. Okay, it comes in a automatic battery-operated, and you press a button, and it comes in the manual one. So a lot of my patients, when we first got these devices, came to me and complained. They said, I got the manual one, and it was very quiet. And then I got the battery one, and when it turned on, it would go, and my kids were in the room next door, and they heard this all. So what do you think Osbon did? They put a muffler on it. Okay. True story. That's a true story. So what you do is when you get a good erection by pumping this device up, you roll off a rubber ring onto the base of the penis. It maintains the blood from going out. Some people complain the penis is cold because it's venous blood as opposed to arterial blood. Some people complain it's floppy where the base, where the ring is on that picture, the penis is floppy below that. The penis extends into the body and gives you rigidity so it's not so floppy. People complain about that. It's a little bit finicky, but it works really well. And the beauty is you pay $500-600 bucks and it's a one-time cost. It's not like insurance every year, okay? And so it's not bad. It's not bad for the right patient. Here's Muse. So Muse is a little pellet that comes in an applicator. The pellet is the medicine. It's Muse or prostaglandin E1. And you put it in the tip of the penis, and it melts into the urethra to give an erection. It takes about 20 minutes. It burns a little bit, but it works not bad in some people. So the advantage of this is that you can use this along with the pills. So if the pills give you a partial erection, and this gives you a partial erection, you can use both. The only problem is in an expensive erection, you take the pills and you take the Muse, it's about 50 bucks an erection. Some people get, it's cheaper to have dinner. So, true story. Okay. And there's injection. So it's funny because we've been, when Viagra came out, we stopped doing injection. It was the #1 treatment before Viagra. We stopped doing injection when Viagra came because people didn't want to do it. They tried this. Now we're back into the motion where we're doing injection therapy. The problem is that if your physician writes you a script and says, here, pick up this injection stuff and then inject yourself, you're going to say, what the hell? Am I going to go home and look around on YouTube how to do this? Really? Believe it or not, people do that, some surgeons. So what we do is people say, can you just give me a script? I say, no, I got to show you how to do it. So we have a pamphlet. They go home with the pamphlet. They come back. I actually show them myself how to inject themselves, how to do it. We see what kind of erection they get. I determine the dose that they need. And then if they get a good erection, people are pretty motivated. And it's an insulin that's very small. Okay, so every time you want to have sex, you have to inject yourself. You give yourself an erection. We taper the dose based on medical problems. It works very well, and most people are very happy with it. The problem is it comes in a vial. You have to purchase it at Toronto General. You can't buy it at Shoppers Drug Mart. It comes pre-mixed. There's another drug called Cavergex, somebody may have heard of, is a pre-mixed or powder and a mixture. That's the only thing that's approved that you can buy in any pharmacy, 3 times the cost. So very expensive. Now, the last thing is the inflatable penile prosthesis. So my wife says I'm a dinosaur because I don't like change, and I don't like change. I hate change. I'm scared of change. And so I use this device as a last resort. So when everything else fails, this is the resort that we go to. And that is the penile prosthesis. So that's the inflatable one, the 3-piece. Gives you the best quality erection that most closely simulates a normal erection. It works really well. The reliability is about 86% at 5 years. 91% of people have a great erection for intercourse, and it works very well. But it's surgery. You need to have this implanted. At our hospital, it's not covered, so it's about $6,100 to pay for it, but it works really well. A couple things about this. One, it'll never be as good as your own erection. It'll never be as long as your own erection. It'll never have the same girth as your own erection. Even after I say that, the first comment people do when they come back after they've implanted, doc, it's kind of short. Okay. Doc, it's not very wide. Okay. Didn't I tell you that? Yes, you did, but I didn't think it would be this short. So what I tell people is, if you want to know how long this implant's going to be, you basically take your tip of your penis and stretch it out, and that's how long I can put in, or how big I can put in a device, by stretching out the penis. When most people see that, they're kind of reluctant to have it done because they thought it would be bigger, but it won't. Now, there are 2 other types of inflatable penile prosthesis. One is the semi-rigid. So that is basically a silicone rod with a wire in it. It bends up or down, but you're always erect. So if you're going to go on the beach with a bathing suit, probably not the best option. So we usually reserve it for people who are a little bit older and don't want to fuss with the pump. And then there's sort of a compromise, the 2-piece Ambicore. And the Ambicore is like the inflatable. You inflate it, pump it up. The difference is there's no button to press to deflate it. You just bend the penis downwards and it automatically deflates. Pretty good idea, because the little button, sometimes people have trouble pressing the button to deflate. So they walk around with a hard on all the time. Not good, because it can erode through. So interestingly, the 2-piece, because it's all contained, it doesn't give you the same quality erection as a 3-piece, but it's pretty close. Now, what about some of the newer treatments? I'm sure you're going to ask me about this. So how many of you heard about the ED1000? Another moneymaker. ED1000 is low-intensity shockwave therapy. Basically, it's a shockwave used for shockwave lithotripsy, but low intensity. And the theory is that if you shock the penis, it improves blood flow. And in fact, it was established by an Israeli bunch of researchers, and they found that this product actually worked. You come in 12 times, they send these shockwaves, it doesn't hurt, it's totally painless, and it increases flow. And there have been 3 or 4 well-done clinical trials that have shown it's worked. But it doesn't work after radical prostatectomy. We've looked at that, it doesn't work. So it costs $3 grand and doesn't work. So I wouldn't recommend doing this. So if someone says to you after radical prostatectomy, this will work, they're not telling you the truth. It does not work. Radiation, we don't really know. I don't see why not, but it's $3,000 if you're willing to spill over $3,000. So I wouldn't spend that kind of money for this, for that, because there are other options that work much better. So my last slide, believe it or not. So ED is common, it's multifactorial. We usually institute lifestyle modification first, then drugs, and then the secondary and third treatments. Sildenafil, tadalafil, and Levitra, they can offer some hope in some people. They work pretty well. And for patients that fail all these, I have a saying, okay? My saying is the following when people come to the clinic. I can give anybody an erection. It depends how motivated you are, okay? Thank you very much.